Now, a little bit further down now, we want to talk about thyroid nodules and thyroid cancer. And I want to tell you, before we do a case, I want to tell you a little bit about thyroid nodules, because before a patient is diagnosed with thyroid cancer, remember, they don't come in saying I have thyroid cancer. They come in and they say, I got a nodule on my thyroid, or somebody found a nodule on my thyroid, or somebody sends this patient to you because they did an exam and found a thyroid nodule in the and they want you to further investigate it. So here's a couple of the rules that we live by when it comes to thyroid nodules. If a thyroid nodule is non-toxic, non-functioning, it is presumed to be cancer until proven otherwise. So if the thyroid nodule is not causing hyperthyroidism, if it's not actively secreting thyroid hormones, if it's not toxic, that is considered to be thyroid cancer until proven otherwise. On the other side of the coin, if a patient has a thyroid nodule, and this patient has hyperthyroidism, so you assume that this is from that nodule, that this patient has toxic nodular goiter, the chances of thyroid cancer are 0. You don't go doing anything to that thyroid nodule because you assume that this is toxic nodular goiter, and if a patient has a toxic nodule, then that patient has 0 chances of thyroid cancer. So basically, when you see a thyroid nodule, your first step is to really assess, does this patient have a functioning thyroid nodule, or is this a non-functioning nodule and I need to think about cancer? And the way you do that is you do a good clinical exam to make sure the patient has no symptoms of hyperthyroidism, and you check a TSH. If the TSH is normal and the exam is normal, then this is a non-functioning thyroid nodule, and that patient has a chance of cancer. I hope everybody understands that we have to exclude 100% of the time thyroid cancer. Now, they tell us some other stuff. Now, you know, nodules that have higher suspicion for thyroid cancer are people that have the highest chance of having thyroid cancer are people with thyroid nodules who've had a history of radiation to the head and neck area. Please be careful of that, because anybody that has a thyroid nodule and they have a history of radiation to the head and neck, this is cancer. It's cancer 9 out of 10 times. Now, they may not tell you, you know, they had radiation to the head and neck. They may tell you this patient 20 years ago got treated for stage 1 Hodgkin's disease. Stage 1 Hodgkin's disease, you know, was treated with local XRT to the head and neck area, right? So that's the kind of stuff that they're going to tell you, that you have to know. So anything about XRT to the head and neck area, that's cancer. Anybody that has a nodule and has lymphadenopathy around the thyroid, right, or in the clavicular area, that has a high suspicion, even higher suspicion of thyroid cancer. Men have a higher chance, if they have a nodule, to beat cancer. Even though most nodules occur in women, women are much higher chance to see a thyroid nodule in a woman, but most of their nodules are benign. In men, because it's rarer to see a thyroid nodule, if you see one, you should have a higher suspicion of thyroid cancer in men. And then elderly patients, when they have a thyroid nodule, elderly patients, you got to think about thyroid cancer even more. But the bottom line is, non-functioning thyroid nodules are cancer. You have to exclude cancer. So what do we do in these patients? Well, take this case here. A 32-year-old man comes for the evaluation of a neck mass, right? You find a 2.5 centimeter thyroid nodule on the left thyroid lobe. There's no lymphadenopathy. The vitals in the examination are otherwise normal, with no evidence of thyrotoxicosis. So they're telling you the vitals in the examination are otherwise normal, with no evidence of thyrotoxicosis, and they'll have here that the TSH is also normal. So I'm going to give you that we checked even the TSH, and this patient is normal. What's the next appropriate step in this case? And the answer is a fine needle aspiration of the thyroid gland. please, I want you to make sure you understand this. If a patient has a non-functioning thyroid nodule, the next step is to do a fine needle aspiration of the thyroid nodule. You don't do radioactive iodine uptake scans. You don't do ultrasounds. You do a fine needle aspiration. In over 80–90% of the time, you'll have the right diagnosis and confirm the diagnosis. Is it benign or is it cancer? And they have to go and get a thyroidectomy. The reason why we don't do ultrasound, because even a cystic mass there, even if it's a cystic mass, you could have thyroid cancer behind the cystic mass. So a ultrasound showing a cystic mass doesn't tell you anything. Sometimes we use the ultrasound to guide us to do the biopsy. That's okay. That's okay, but we don't do the ultrasound to look for a cystic mass and say to our patient, this is a cyst, I don't have to worry about it. No, we have to do a fine needle aspiration always. The reason why we don't do a radioactive iodine uptake scan, because if a patient has a normal thyroid function, remember you assessed this guy clinically for thyroid function and you did a TSH which was normal. If a patient has normal thyroid function, then if you do the radioactive iodine uptake scan, you're going to get one of two results. You're going to get a cold nodule or you're going to get a warm nodule. The cold nodule has a higher chance of cancer. The warm nodule has a lower chance of cancer, but still has a chance of cancer, so you still have to do the fine needle aspiration. The reason why you won't get a hot nodule is because this patient has normal thyroid function. You're not going to get a hot nodule. A hot nodule is a toxic nodule. So just by doing a good exam in the TSH, you excluded that case. That's why both of these tests, if you do the next step in this case, you either get a radioactive iodine uptake scan or you get an ultrasound. That's the wrong answer. It's the wrong answer because that's not what you do. You do a fine needle aspiration. If a fine needle aspiration is done and it shows an adenoma, right, benign, you don't forget about that patient because sometimes you could miss the cancer. So what they ask you to do is, what do you do after fine needle aspiration? It shows benign adenoma. You say, okay, fine, this is benign adenoma. What do? I bring them back 3, 4, 5, 6 months later to make sure this hasn't grown in size. If it grows in size, then you have to rebiopsy it. If there's any lymphadenopathy later, you have to biopsy it. They may ask us sometimes, some patients have multiple nodules. Well, which nodule do we biopsy out of the multiple nodules? And the answer is, we biopsy the biggest nodule. You pick the biggest nodule, and that's the one that you biopsy. They sometimes ask us, a patient that has had a fine needle aspiration of a thyroid nodule comes back 1.5 years later with a new nodule. What do we do about it now? Do we tell them it's a benign nodule like the one 1.5 years ago? Or do we biopsy it? And the answer is we biopsy the new nodule. Patients that have one nodule may get a second nodule, but the second nodule that they get doesn't always mean it's benign because the first nodule that we biopsied was benign. So please be careful of that. Always biopsy new nodules. If we diagnose thyroid cancer, the most common thyroid cancer that we find is papillary cancer. And that's the most benign one. That's the one we want because that has great potential for treatment. 95% of those cases are cured. And look at this. What do you do next? You send that patient to a surgeon. What does the surgeon do? They do thyroidectomy. What thyroidectomy? Total thyroidectomy. How does the surgeon know they took out all of the thyroid gland? They check thyroglobulin levels to make sure the thyroglobulin levels are low and they resected the whole thyroid mass. Or else they go back in. If there's thyroglobulin levels that are increased or there are any thyroglobulin levels, you go back and you check to see if you got any residual tissue and you remove that. If a patient with thyroid cancer comes back to us years later, how do we follow disease? Well, one of the things that we do is we check thyroglobulin levels. Again, it should be always 0. If the cancer reoccurs, we check thyroglobulin levels and we find them elevated. as we follow disease activity. There's one exception to what we do after, what we do is we send them to the surgeon or we follow them when you do a fine needle aspiration. If you find papillary cancer, then the answer is easy. If you find papillary adenoma, it's benign and you know what you got. But if you find follicular cells, remember, follicular cancer is the second most common cancer of the thyroid after papillary. Follicular cancer looks on the fine needle aspiration just like a follicular adenoma. And you can't tell the difference between those two. So if the fine needle aspiration comes back and it says, I got follicular cells, do I have cancer? Do I have an adenoma? You don't know. And what you have to do in that case is you have to send that patient to the surgeon. What they do is they remove the whole nodule while in surgery. They do a quick evaluation if it's thyroid cancer or not. And then if it's thyroid cancer, they go back and they remove the whole thyroid. So follicular cells on the fine needle aspiration look just like the adenoma, and the cancer looks exactly like each other. So what you have to do in that case is you got to go and resect the nodule, look at the architecture, see if there's any infiltration or anything like that that would point towards cancer, and then if it's cancer, follicular cancer, you go back and you do total resection of the thyroid. That's a small percent of the patients because most of the cases, like I said, you could diagnose if it's benign or cancer because most of these cases are papillary types and so forth. So I want to give you a little bit more on the thyroid nodules. We said that the first step that we do after we confirm that the patient is euthyroid, basically clinically and by a TSH, is to do a fine needle aspiration. So look at this. They give us a patient with a cold nodule. Now look at this here. This is a radioactive iodine uptake scan. This is not the next step. They shouldn't have done this, but they gave it to us already. Somebody else did it for you. Okay, so you're stuck with this. Look at this. Now I just want to make sure you understand. Look at this here. The uptake here is okay on this lobe. Here the uptake is okay, and look at this. This is the cold nodule. Cold nodule means, no uptake here. Right here, this is the radioactive iodine scan. It means it's cold. It's not producing anything, and this is a high risk for cancer. But you already knew that. That's why you could forgo this test here, because you already knew that. How did you know? Because your exam showed a normal thyroid function, and the TSH showed normal thyroid function. So this could only be a cold nodule or maybe a warm nodule. Warm is like when there's little uptake there. But bottom line is, you knew that this was coming up just from the exam. That's why we do a good exam, we get the TSH. If that's normal, we go on to the next step, which is a fine needle aspiration. Are there any exceptions to the rule? The answer is no. There are no exceptions to that rule. Everybody has to get a fine needle aspiration. Please, please remember that. Now, let's talk a little bit about thyroid cancers, and I want to tell you just a little bit on this, basically so you could be able to answer some of the question. We'll talk about the first one, the most common one. We said about 70% of the cases of thyroid cancer that we see out of the total of 100%, 70% are papillary cancers, and this is the one that's associated mostly with radiotherapy to the head and neck area. The papillary cancer is a very treatable cancer. The survival on papillary cancer, 95% of those patients live to 10 years or more. So very good survival, very good disease to treat. It's a very good cancer to have if you're going to have a cancer. Now, the metastatic potential, it usually metastasizes to the regional lymph nodes. It is very rare for papillary cancer to go to hematogenic spread, to have metastatic to bone, to liver, to other organs. Very rare, only to the regional lymph nodes, and it's very treatable. Follicular cancer we have to know just a couple things about follicular cancer. It's the second most common cancer. The prognosis is a little bit worse than papillary cancer. It's worse. They don't do as well, but it's still a good cancer because it's treatable. Now these patients are a little bit older. Papillary cancers, the patients are younger. Follicular, they're a little bit older, and they ask us sometimes a question about a patient with a thyroid cancer, and they tell us this patient has metastatic disease to the bone or to the liver or to the bone marrow and something like that, and they're trying to tell you, they're asking you a question about which likely thyroid cancer is this, and the answer is follicular, because with follicular cancer it is common to see hematogenous spread. It is common. So this is the cancer, the thyroid cancer that spreads hematogenously to distant sites. The fourth cancer that we need to know a little bit about is medullary cancer. Actually, this and papillary we have to know the most about because they ask a couple questions about this. Now, medullary cancer is the calcitonin cells, the parafollicular cells, the calcitonin secreting cells. So it's not the typical thyroid cancer. It's kind of like a neuroendocrine disease, basically. Medullary cancer is. And the interesting thing about it is that it has familial forms of cancer, something we don't see in the other thyroid cancers. It's associated with two types of multiple endocrine neoplasias, where we see other neoplastic lesions too, and it's associated with multiple endocrine neoplasia 2A and multiple neoplasia 2B. We're going to talk about this later, about these multiple endocrine neoplasias, but it's also associated with solitary familial medullary cancer. I want you to remember that because they ask about that. They ask us which, somebody in the family, the father had thyroid cancer, no other tumors, the brother had thyroid cancer, in the family, no other tumors. What kind of thyroid cancer is this likely to be? And the answer is medullary. You could have solitary familial medullary cancer. So that's we have to know that stuff about medullary cancer. Then the last one is the rarest form, and its most aggressive form. It usually occurs in older patients, and this is anaplastic cancer. So it's rare. It occurs in older patients, and it has the worst prognosis out of all the thyroid cancer. In fact, it has the worst prognosis of some of cancers all around. It's probably one of the worst prognosis cancers to have. It's exactly the reverse of papillary cancer, where less than 5% of those patients with anaplastic cancer from the time they're diagnosed live to just a couple of years. So very aggressive cancer, the exact opposite of papillary cancer. And the interesting thing about this anaplastic cancer is it invades all the areas around the thyroid. It doesn't metastasize to distant sites, but it invades all the tissue around it, basically causing infiltration of the trachea, the big vessels, the esophagus. Very, very aggressive form of thyroid cancer. And as I said before, basically these patients live only just a couple of months, maybe a couple of years. The treatment for all thyroid cancers is total thyroidectomy. Total thyroidectomy, that's the treatment of choice. And then, as I said before, you want to do a couple of things that are standard in thyroid cancer treatment. One is you want to make sure you didn't leave in any residual thyroid tissue. And how do you do that? You check thyroglobulin levels. Then, when you're following patients, let's say they come to you 6 months later, 1 year later, a year and a half later, what you want to do is you want to find out if the cancer has reoccurred. So what do you do again? You check thyroglobulin levels. If you did good total thyroidectomy, thyroglobulin levels should be 0. When the patient comes to follow up with you, if there's no recurrence of disease, again, thyroglobulin levels should be 0. So please be careful of that. That's the way to follow disease activity. The last thing I want to say is this thing here about suppression of TSH. Now, this is a very important concept in thyroid cancer treatment. Most people believe that even thyroid cancer cells have TSH receptors. And what you want to do after you want to do total thyroidectomy is you want to give enough thyroid hormones, not only to make the patient normal thyroid function after you remove the thyroid, but a little bit more than normal thyroid levels to suppress TSH. The reason why you're suppressing TSH is to basically inhibit any recurrence of thyroid cancer this way. Because even if you have a little bit of a couple of thyroid cancer cells in the body, they will be activated by TSH because they have TSH receptors. So what you want to do after you remove total thyroidectomy, you want to give supranormal amounts of thyroid replacement treatment to suppress TSH. So let me give you an example. We said before that basically the normal amounts an adult needs of T4 is about 125 micrograms to maybe 200 micrograms, more or less, for daily doses. These patients, you will give them a little bit more to suppress TSH. For example, it is common to see patients with after thyroid cancer treatment to receive 250 micrograms, maybe even more, 275 or 300 micrograms in order to suppress TSH. So be careful, because they may give us a patient like that on the boards, where they're giving us a patient and you're saying, like, why are they giving them so much? They're giving them so much because it's intended. They want to suppress TSH. How long do you do that for? You do it for 10 years after thyroid cancer treatment. And after you do it for 10 years, if the thyroid cancer hasn't come back, then you go back to giving this patient normal thyroid hormone levels. You're basically giving them normal amounts of thyroid hormone after that, because you don't need to suppress TSH further than 10 years. You don't want to give them beyond 10 years, because giving them too much thyroid hormones causes osteoporosis, so it has, side effects. It's not benign, but in the short run, in the first 10 years, in the short run, you want to protect this patient from thyroid cancer. That's why you want to give them a lot of thyroid hormones to suppress TSH. Now, here's another concept. One of the things we like to do is to give a more potent thyroid hormone back, because maybe by giving a more potent thyroid hormone back sometimes we suppress TSH better. So it's common to see after thyroid cancer surgery either to give a lot of T4, like I said, 300 micrograms or 250 micrograms of T4, or to give T3. Because remember, I said T3 is more potent, and the feedback back to TSH is more potent, so you could suppress TSH better that way. So here's another possibility where you may want to know that you could use T3, is to suppress TSH after thyroid cancer removal, total thyroidectomy. So I want you to remember that. So please remember those concepts about thyroid cancer. Having said all that, let's do this case. So a 34-year-old woman presents with a history of papillary thyroid cancer removed 9 years ago. She takes Synthroid 250 micrograms per day. Her exam is unremarkable and her TSH is low. Look at this. This TSH is low here, right? And free T4 is a little bit elevated here. The upper limits are normal. I told you, depending on the lab here, is either about 5 to 7. This lab was about 5, so it was a little bit elevated. So my resident came in and said, listen, we have to suppress the Synthroid because they're giving her too much. And I said, well, why is she taking Synthroid? And he said, well, she's had thyroid cancer 9 years ago. And the answer was, well, that's what they wanted to do. That's what the endocrinologist and the oncologist wanted to do. It's intended. This is what they want to do. They want to do this for 10 years. She's already taking this 9 years now. And then, if this goes on till next year, well, then you're going to down her dose. You're going to reduce her doses of thyroid medication, Synthroid. But basically, what you do now, what would be the appropriate adjustment in her thyroid replacement treatment? The answer would be, leave it alone. Don't do anything. This is intended. The reason for doing this is to suppress TSH in order not to activate any redundant thyroid cancer cells in the body. That's the bottom line. So please remember that.